Hello and welcome to the channel. Today I am here with a case of traumatic cataract in a young patient of about 20 years of age who sustained a blunt trauma injury to his right eye. As it is well known that the anterior capsule in young patients is very elastic, so it's always a very good idea to stain the anterior capsule with Strapan blue dye. So first, it helps in the better visualization of the anterior capsule, and second, it also helps to reduce the elasticity of the anterior capsule. Owing to the elastic nature of the anterior capsule, there are always the chances of the anterior capsule running to the periphery. So in this case, I am aiming for a small rhexis. The rhexis has been initiated using a 26 gauge bend needle cystitome, and the flap is gradually moved. Now a microcapsular rhexis forceps is being taken and the tearing edge of the anterior capsular flap is held and gradually moved. Making a capsular rhexis in young patients is slightly tricky, and the forces which are applied in such a patient, they are directed towards the center. The capsular flap is being pulled, held from the tearing edge and pulled towards the center. In these cases, we all initially aim for a small rhexis and eventually end up having a larger rhexis due to the elastic nature of the capsule. A rhexis of about 4 to 4.5 millimeters is completed. Now is the time to make the main port. It's been made using a 2.8 keratome. The lens in these cases is usually soft, and here I have done hydro dissection and delamination. As the lens matter was very soft, I didn't feel any use of phaco handpiece, so I have taken a coaxial irrigation aspiration handpiece. As I have a small rhexis, I'm finding it slightly difficult to take the epinucleus and the remaining cortex out of the capsular bag. Here I am doing visco dissection of the remaining cortex and the epinucleus so as to bring the lens matter in the center, which can be easily removed from the eye without much problem. Visco is now injected from the side port, and visco dissection on the other side is being done so as to get the lens matter out. In this case, I am implanting a preloaded intraocular lens CT Lucia from Zeiss. No financial interest, and the lens goes comfortably into the capsular bag. Now is the time to enlarge the capsular axis, because in young patients there are more chances of capsular phimosis. So a micro scissors has been taken and a nick is being made at 6 o'clock at the margin of the rhexis. Now with the help of a micro capsule rhexis forceps through the side port, the rhexis has been enlarged to an optimum size. The remaining viscoelastic has been removed. Both from the front and the back of the intraocular lens. All the incisions closed, and that is the end of the case. Thank you.